Today I'm presenting some results from the Community Corrections Hepatitis C study, otherwise known as See No More, which has been operating for nearly 2 years in metropolitan Melbourne. We're actually expanding services to include other blood-borne viruses and STIs, as the title suggests, but I'm going to present data from phase 1, which is hepatitis C only. And I just want to shout out here to our peer worker, Mark Belter, who did the artwork for the logo. So I'm on the unceded lands of the Bunurong people of the Kulin Nation in the inner west of Melbourne, and I pay my respects to elders past, present and emerging, and extend that respect to the traditional owners of the various lands that people are joining from today and any Aboriginal and Torres Strait Islander people here. And if you're not familiar with the Torch, which is a statewide Indigenous arts in prisons and community program in Victoria, get on the website there and have a look. This artwork was done by Stacey, who is a Taungurung Bunurong woman with traditional connections to the Melbourne region. And this artwork was purchased by Burnett as part of our Reconciliation Action Plan. So the See No More study has the usual cast of thousands, but critically it's a collaboration between 3 organisations which individually oversee the clinical research and peer aspects of the study. And I just shout out before I continue to Samara Griffin, from whom I borrowed several slides for this presentation, and Samara's doing a PhD on the phase 1 outcomes. So first off, a bit of background and context. I've assumed that there's some base level of hepatitis C in my presentation, but I've gone through a bit of detail to kind of make sure that everyone's understanding all the elements. So since 2016, highly effective direct-acting antiviral treatments were made available on the PBS by the federal government, including for people in prison, which, as you'd all know, is pretty rare. And since 2016, more than 60% of people living with Hep C have been treated in Australia. But we've seen declines in testing and treatment quite substantially in recent years. And we now know that we need to adapt healthcare approaches in order to reach the remaining 70,000 people. And this may include being creative about the settings that we may offer healthcare, which don't already or have healthcare, or adapting existing healthcare services to better meet people's needs. Now, the diffusion of innovation theory provides a useful framework to consider people's readiness to engage in hepatitis C treatment. So the first half here, the first 50%, reflects the people already treated, while the second half highlights the hesitant, doubtful, uncertain and unaware who might need further adaptation and innovation of existing services to make them more accessible and suitable to their needs. It's well established that people who inject drugs are the group most at risk of hepatitis C transmission, and we know that there's still significant barriers for accessing testing and treatment for this group. These include stigma, unstable social and financial situations, competing life priorities, venipuncture requirements for testing, multi-step hepatitis C cascade of care. And critically, the criminalisation of drug use results in a high prevalence of hepatitis C among incarcerated populations. The latest data from 2022-2023, this is from the AUSHEP study, show that hepatitis C prevalence in prisons nationally, it varies considerably by jurisdiction, but overall is 8% nationally. Yeah. Compared with around 1% in the community. So this figure's from the 2024 Annual Progress to Hepatitis C Elimination Report and shows us that hepatitis C treatments in prison make up nearly half of all treatments nationally. However, there are thousands of people who are involved in the criminal justice system who don't pass through prisons and may avoid traditional healthcare settings in the community. And we don't want to send them to prison in order to get them treated. So while in-prison programs are comprehensive, there are gaps in the community continuity of care. People may choose not to be treated in prison. Some people may not be incarcerated for long enough to initiate treatment. Others may be released prior to treatment completion. and the siloed nature of prison and community services means they often fall through the gaps. So community corrections may provide an alternative contact point to provide healthcare services for these groups which are being missed, as well as being a setting which allows for screening of a high volume of people. And if we look at the Victorian corrections population, at the start of this year, there were just over 6,000 people in prisons, but over 10,000 on community corrections orders, roughly half of whom have never been to prison. Community corrections functions to supervise people in the community as an alternative to prison or as a condition of release, including probation and parole. They're likely to have similar risk factors for hepatitis C as people in prison, with similar levels of lifetime injecting drug use. However, in Victoria, there have been no programs offering hepatitis C care to this population. And the structure of community corrections supports healthcare delivery as regular required reporting on site provides a recurring touch point to engage and retain people in care. So we were inspired by Hepatitis Queensland on-site community corrections program, and we set out to establish a streamlined test and treat service for hepatitis C in metropolitan Melbourne. In Victoria, there are around 50 community corrections sites, which are quite geographically distal. This figure shows there's about 20 here in the metropolitan region, or the Greater Melbourne area. So most of you will know that community corrections officers are administrative in nature and don't have clinical infrastructure, systems, or policies to support that kind of operation. So setting up a healthcare service in that setting requires taking everything with you to be able to be self-contained. In Queensland, they run the GP-led on-site fortnightly rotating clinics, and they pack it all up and take it with them. In Victoria, we were unable to establish our program on-site physically, so we innovated with a mobile model, and more of that to come in a minute. But first, another piece of the puzzle. So some of you will know that standard care for hepatitis C testing, diagnosis and treatment initiation typically involves multiple appointments, which are arduous for people to attend. So they might require, first of all, a test for exposure, an antibody test, followed by, which will usually require referral to pathology. So a phlebotomist will take the blood, it will be sent off to testing. They'll get the test results, and then they might, if that's positive, showing an exposure to hepatitis C, they'll get the viral test, which they have to go back to the phlebotomist for, and then they'll get the diagnosis from the physician, and that's even before they've got to the point of treatment. So point of care testing technologies can cut out these multiple steps and can also be conducted in non-healthcare settings, meaning we can take the test to the people and thereby reduce at least some of the barriers to hepatitis C care for some groups. So we're using the INSTI to screen for hepatitis C exposure. So it's an antibody test. It requires only a finger stick blood sample and returns a result in about 1 minute. And it's been TGA approved now. For people who've already been exposed to hepatitis C, the viral load test, so this is a test which is testing for current infection, which is conducted with the Cepheid Gene Expert machine, and this returns a result in an hour. So with these technologies and a van, we developed the See No More model of care. It's a nurse and peer-led clinically equipped van that parks outside of community corrections offices, and it provides point-of-care testing and rapid treatment initiation. Our model of care starts with van staff who approach people in the vicinity of community corrections offices. So this includes community members and people going in and out of their corrections appointments. And we didn't restrict to people on community corrections orders. The locations of our vans means outside community corrections offices means it's usually nearby to other government services like Centrelink, courts, Department of Families, Fairness and Housing. There might be job seeker providers, there might be NDIS providers, pharmacies, train stations, public libraries. So we get a lot of foot traffic. After recruitment, the consent and baseline survey is conducted and followed by a point of care test. So if someone says they already know they have Hep C or they've had hepatitis C before, they skip this antibody test and go straight to an RNA test, which takes 60 minutes. As I said, we run this off a portable battery in the van. And then for individuals who test positive, we can organise a prescription through our study nurse practitioner or gastroenterologist. Medications are dispensed either through St Vincent's Hospital pharmacy and via the van, or through local pharmacies who've established relationships with. Participants could also choose to have their medication dispensed through a pharmacy where they're already getting OAT. While people are on treatment, the nurse and peers provide personalised support, including reminders and check-ins. So it's a really streamlined, low threshold, flexible and supportive model of care with the aim of making it as easy as possible for people to start and stay on treatment. So here's our outfit. This is Mark Belter, our peer worker, Bridget Reed and Georgia Myers, who are our hepatology clinical nurse consultants. You can see we've got a nice big awning for rain cover and shade in the summer. We've got this new sandwich board, which Mark designed. And you can see here that, we're mostly set up in car parks or by the side of the road. Inside the van, it's a pretty basic setup. We've got a phlebotomy chair and we've got some drawers that stay shut for motion. And on the top here, you can see this is the Gene Expert machine. Oops. It went clicked. Here's the Gene Expert machine. Here's our portable battery. Here's our sort of work area, and there's not much room for anything else. So we're using a mixed methods design to evaluate the model of care, and this is forming the basis of Samara's PhD. We're utilising clinical, operational, survey and interview data to determine the feasibility, acceptability, effectiveness and cost per cure of the model of care. So moving on to some results. So the study started recruitment in September 2023, and so far we've tested just over 1,000 people. 74 were RNA positive, so we have a prevalence of about 7%. And you'll remember that the national prevalence in prisons is around 8%, so it's quite high. We've had 62 people initiate treatment, which is about a 90% treatment initiation rate, with 5 treated elsewhere included. 41 participants have been confirmed to have completed cure so far, and 39 have confirmed cure, and 2 did not confirm cure due to medication non-adherence. Just to break down our population a bit more, and I know this slide's a bit busy, so apologies for that. But you can see that only a third were currently on community corrections orders at the time of testing, but 75% overall had a history of criminal justice system involvement, which we define as either having been to prison or had previously been on a corrections order. The cohort is mostly men, 14% identified as Aboriginal or Torres Strait Islander, 14% had no fixed address, nearly 40% were recent injecting drug users, and nearly 20% were previously injecting drug users. And 20% had been previously treated for hepatitis C. So while overall our prevalence of Hep C was around 7%, looking at different groups, that's 14% among people who currently inject, 6% among people on community corrections orders, 10% among people who've previously been imprisoned, 13% among people on opioid agonist therapy, and 10% among people with no fixed address. And just a little look at the people who tested positive here. 90% had a history of criminal justice involvement. I'll let you read through some of those, but I think the things I want to highlight here is that 29% had no fixed address, 53% had a diagnosed mental illness, and more than 10% had no direct means of contact, so they didn't have a mobile phone. So we've really reached a population who have a fair bit of significant social and health disadvantage, and were not engaged in other kind of healthcare mostly. So everyone who tested positive on the point of care test were encouraged to undertake venipuncture for pre-treatment workup. And 49 of these people had liver function testing, and around 23 had results that were indicative of liver fibrosis. 12 completed FibroScans, and 7 people were determined to be cirrhotic, and 2 we detected liver cancer. The median time to treat was 10 days. In many cases, we would, I think about 50% of the treatments were dispensed through the hospital pharmacy and then back through the van. So most of the time that would require people coming back to the van to pick up their meds, which worked fine. But you can see that it took a median of 29 episodes of contact throughout to the treatment to initiate and complete it. And this is sort of I guess, reflects the high needs that we saw in this group. So Samara led an accessibility evaluation for this model as part of her PhD, using survey data from the beginning of the study to July 2024. We had survey data for 500 people at that point and conducted in-depth interviews with a sample of 20 people. So people asked about point of care testing, their experiences with the van and other healthcare, how they felt about street-based outreach and the use of the van as a clinical setting. And we purposively sampled participants based on gender, study location, criminal justice and injecting drug use history, and hepatitis C history to gain a broad perspective of views and experiences. So I'll just quickly touch on the results here, which are presented in the framework that we used. It had 5 components that relate to both the service and the individuals using the service. So first, for approachability and ability to perceive, participants reported that the informal casual setting made it more approachable. Regarding participants' ability to perceive themselves as being at risk of hepatitis C, generally they didn't, and they didn't perceive their behaviours as putting them at risk for hepatitis C either. And this was even true for one participant who said here, yeah, I thought I was fine and I seen the van here again and I came down and got tested and I couldn't believe that I had it, yeah. For acceptability and ability to seek care, interviewees felt that the comfortable, easygoing environment increased acceptability of the service, as did the involvement of peer workers. For availability and ability to reach, the location of the service was important for increasing availability, as was the low threshold drop-in service. Regarding affordability and ability to pay, so we paid dispensation, like the gap fee for pharmacist dispensation. So it was entirely free for people. And we also provided vouchers as a reimbursement for people's time. And this increased participants' perceived affordability of the service. And finally, for appropriateness and ability to engage, the rapid testing really increased people's perception of the ability to engage. As one participant said, they don't have to butcher your arms, you don't have to wait weeks for results. You can just come in, get the finger prick done, and everything will be organised from here pretty much. Interviewees also appreciated the supportive model of care, with care being coordinated by the nurse. So insights. So we're still going, but one thing that became apparent really early on was location is everything. And like I said, being close to all these kind of services that people use on a regular basis really, really fed into us getting the right population. We found that we accessed a group with really high support needs, which was very labour intensive in terms of resourcing and staff time. And we really needed to be flexible in terms of how we delivered services. Communication and relationships with community correction sites was really key. So that took a long time to set up. It took us several years to actually establish endorsement from community corrections to be able to run this and have them on board. And now they're fully on board now that they see how it actually operates and the results that it's producing. So we're expanding to new services, to new sites at the moment, and it's been very smooth compared with earlier communications. The challenge of DAA dispensing. So this was an unforeseen challenge. The original model of care was to have community pharmacies, local community pharmacies that we could literally just send the script down the road with the person, even take them with us and get them dispensed. But actually that wasn't very viable because most community pharmacies didn't want to stock the DAAs because it's essentially a financial liability for their business if somebody doesn't pick up the medication. And the last thing I think was really critical was the link with St Vincent's Hospital statewide hepatitis program. So that's the in-prison hepatitis service, so that we could really provide that continuity between prison and release and also refer, cross-referral. So what's next for this study? So Samara's working on a primary outcomes publication and a cost per cure analysis in phase 2, which is starting in a couple of weeks. We are expanding services to include testing for sexually transmitted infections and rapid treatment access for people infected with sexually transmitted infections. That was a mouthful. And vaccinations, starting with hepatitis B and flu, and we'll see where that goes, whether we can do more. And we continue our investigations and advocacy for a sustained approach. So I just want to acknowledge the participants and the organisations and individuals who have supported this study with funding, in-kind support, resources and knowledge. Thank you.
Awesome. Wow, that's like a really cool program. And I love that it's such a great public health intervention. It looked like, and I guess one of my quick questions that I have for you is, it looks like it also benefits the broader community because you don't have to be coming from the community corrections to access the service, but it sounded like 75% of the people that were accessing it were, but that other 25% are obviously people that just low barrier threshold access to something like that. And yeah, very innovative indeed.
Yeah, and I think the convenience as well.
Absolutely. And I would imagine, the population, especially those experiencing homelessness and justice contact and drug use and mental illness, often experience a lot of barriers accessing healthcare and a lot of stigma. So such an inviting service that you're providing, and clearly is really helping. Um, does anyone have any questions? We have time for a lot of discussion.
Yeah, hi, I'm Donna Mack. I'm a public health physician and I work in communicable disease control in Western Australia. Well, thank you very much for the presentation. It's really, really interesting and very inspiring. But I was intrigued by the fact that people said that they didn't think they were at risk. And I'm wondering, why do you think that is? Do you think it's lack of information, or do you think it's, there's just sort of a cognitive dissonance between one's behaviour and what one actually knows theoretically to be true?
I think there's there might have been very mixed there. I don't think there'd be any one clear reason. But in many cases, people say that they're very careful with their injecting behaviours, but perhaps they've missed something.
Yeah.
Or they've, had an early exposure before they knew about hepatitis C.
Yeah.
So interestingly, we did have, actually, I'll come back to that point, but I think, yeah, that's something that we could probably investigate a bit more. I think, Samara, you did the qualitative interviews. Do you have any further comments to add to that?
Sorry, I'm not sure if you can hear me.
You
I think it
can.
was okay, great. I think it was really mixed in terms of how people felt that Bec was right. So some people came knowing that they had quite high likelihood, whereas others were just really, really confident that they had been really careful. I don't know, and you kind of even when they sort of spoke about their behavior, they didn't really see any risk or any likelihood that they would have hepatitis C, but it was a pretty mixed bag, I think. Yeah, I'm not sure. Even people who had had hepatitis C before, who had maybe had some risk recently of recontracting it, didn't really identify that. So I'm not really sure what factors made people think that they might have been at risk or not. Hard to say.
Thank you.
But with the interviews, when I've been out in the field, I have been struck by there seems to be a real polarization, polarization of knowledge. People have either really good knowledge or they have very little in terms of their hepatitis C understanding.
And does the knowledge actually translate into people's understanding of their own risk and their behaviours, or I mean, because knowledge, we know there's often gaps. So I'm just wondering whether that actually makes a difference, having a lot of knowledge.
I think life happens, and people find themselves in situations where sometimes the knowledge is there, but life happens.
Yeah. And for the people who didn't have knowledge, were they, was there any particular characteristics that we might take from that to say that these are groups that need more education because they don't have the knowledge? They, I don't know, for example, non-English speaking background or.
I think yes, there's definitely a need for more education in this group. Yeah.
Okay, thank you. I'll be quiet because I'm sure other people have questions they want to ask of you too.
If you have more, Donna, you go for it. No one's got their hand up yet, so come one, come all. Maybe I'll ask a question and then others can think in the background. I'm just wondering, Bec, are you aware if the Queensland program did any similar evaluation, and did they find similar things, outcomes, and also just experiences of people accessing the program and adherence? And if not, why that might be? Was it implemented the exact same way? Obviously, there'd be differences in the populations.
Their model of care is a GP, and they have a phlebotomist that goes with them, who's provided by Queensland PAC, and they have a nurse and a peer worker, and they go on site. They started with one community corrections site, and they did fortnightly half-day clinics, and they've slowly expanded. I think they go to 5 different sites now and a court. And in some places it's monthly clinics, in some places it's fortnightly. So it's a lot less consistent. It's also quite expensive being GP-led. I think there was some very complicated ruling around Medicare that the GP wasn't able to claim Medicare for the appointments because it was not an accredited location. I cannot remember all the detail of this, but it was
right.
Yeah, so they pay the GP to come and write the scripts. So they have a very different operation in that while they're recruiting opportunistically, most of their referrals by approaching people in the waiting room, but most of their referrals come through their community corrections staff. So people are kind of identified as someone who might be at risk. But they found a much higher prevalence of 17%. And they've been operating since about 2020, I think it is.
Wow, okay.
Sorry, did I get all of your question there?
Yeah, I mean, it was a kind of a broad one, just around, you know, I guess was there anything that you didn't expect or was surprising, and particularly in relation to what they found in Queensland? So I think you've, or maybe Samara, even if you
Look,
questions.
so yeah, by necessity, we had to operate very differently because we were unable to go on site. So we talked to them a lot about the different ways that they engaged people, and adopted many of those. They were very much our mentors as we started. But I think, yeah, for them, they were like, they started with venous blood samples as well, and then they went on to the National Point of Care testing program, and now they have a similar streamlined process. But yeah, just lots of differences.
I'm really interested in what you were mentioning around the comorbidity in the population, which isn't surprising. And I guess I've kind of two related questions. Do you think this model could work for other health issues? For example, I guess the closest one being HIV or opioid agonist treatment or even mental health supports. And I'm just wondering if you could speak to how the program and if and how the program can connect people with other providers, and what the imagine
Yeah,
it's quite challenging, especially with the
it is. My dream is to make this a primary healthcare service. But yeah, we have limited funds. And what we need to do is demonstrate that it works the way it does before we can start to add on other components. That said, we are, expanding to the STI testing and vaccinations. And part of the rationale for that is, apart from meeting need, is also that we are hoping that it will increase efficiency and reduce the cost per contact. So it's better able to be, financially sustainable in the future. We've got a grant application in at the moment to add an AOD case coordinator to the team 2 days a week, because we're finding that, obviously that is one of the highest needs in terms of healthcare. The other thing that I think I would really like to do is a housing worker, because it's housing crisis that really pulls the rug out from under people's feet, in terms of their ability to engage with healthcare and stay engaged. I think the nurses, because we're operating under a research protocol, we are limited in terms of what we can offer outside of that, but we do have a strong referral system. We make sure we've collected local referral information. People can be supported to attend those appointments when needed, like we are restricted, but the peer worker, he's amazing. His ability to connect with people one-on-one is really incredible. And he can, when there's some hesitation, he will actually go and pick someone up and take them to an appointment, or walk them down to the local service and kind of support them through. And we find that bridge really, really helps. So I think, yes, I would love to be able to expand this. I think the need is there, but the resourcing is another matter.
And a huge budget line item would be a much bigger bus than what you currently have.
Yeah, absolutely. With a more reliable battery.
Absolutely. Yeah, that's just really awesome. And again, if there's no other questions, I've got a few more, unless Sarah.
Hey Bec, thank you so much for a great presentation. I really love the quotes about the peer workers and what you just mentioned. I'm kind of wondering in terms of scalability, what would you have, do you identify what challenges there are in terms of peer support?
Peer support, as in the peer worker being supported, or
Yeah, well, in both ways, like employing peer workers to provide that component of the service, I guess.
yeah. So there's a couple of different options, I think, in terms of how you could scale up. So New South Wales have an interesting model where, so they have the local health districts. Sorry, I don't know where you're from, and I don't know if I'm,
No, I'm in Perth, so yeah. This is
Okay, so they have the local health districts and nurses attached to these local health districts that do that, have their sort of catchment area where they operate.
Yeah.
And what Hepatitis New South Wales have done is created a peer workforce that they can roster out to work with the nurses whenever it's needed. So they don't have like a regular, so I think some local health districts will go have a regular clinic at a community corrections office, their local community corrections office, say monthly, whereas other local health districts will be ad hoc. But each time they can contact Hepatitis New South Wales for their peer workforce, which is managed through Hepatitis New South Wales, so it's well supported through their structure, and having other peers as part of their culture, like work culture, to be able to have that sort of distribution as it's needed. I really like that model. The way we work is we brought together like the 3 organisations to collaborate, and I felt it was really important that the peer worker was directly employed through Harm Reduction Victoria in our case, and not through the hospital, so that they are well supported in terms of supervision from a peer, having that work environment and culture that is more suitable for them, rather than being put into a clinical environment with no real support. And we've set up, so I guess another thing that is sort of quite unique to our model is we try and do collaborative decision making wherever possible in terms of implementation, and that involves a weekly meeting that everyone comes to, and decisions about operations are discussed, and so that's a place where things can be raised. Secondly, formal supervision will occur for the peer worker through Harm Reduction Victoria. And thirdly, the coordinators, so me from Burnett, the nurses from St Vincent's, and the peer workers supervisor, which is Jane Dicker from Harm Reduction Victoria, we all come together fortnightly and just touch base and make sure we're all on the same page, and that, we just try and identify things as they're coming up that we can monitor and provide support for.
Wow, you really thought of everything there. That's awesome to hear.
And the other, I think in terms of providing the other part of your question, the sustainability or scaling up peer workers, I think it's like it's entirely possible, but I think we need to provide better support and pathways for peers to take that career direction. It's very difficult when there's, ad hoc kind of bits and piecey projects going on to provide that sort of professional development and support. Mark quite openly says, because we go and do information sessions at community correction sites before we start, and we take the whole team and they get to meet everyone, and they get to come and have a poke around in the van, and all the staff, like we try and really bring them on and get them on board. And, we are very clear about how the makeup of our team is a critical component. So it's the clinical expertise, but it's also the cultural expertise and life expertise that support to the team through Mark. And he quite openly says to the staff, I didn't have a job for 30 years and I've now held down this job for 2 years. And he's very, like, we just think he's such an asset. But we'd love for there to be, more formal professional pathways for people like him who have this, bring this incredible expertise and things that no one else can bring, but are not well recognised perhaps in that development. In terms of development.
That sounds like a really important next step, is professional pathways for peer workers.
Yeah.
Thanks, Bec.
Go ahead, Cameron.
Oh, yes, thanks, Bec, for the information on the wonderful project. I was just wondering, with prisons, so Queensland are going into prisons and we're not able to in Victoria. Do you have an indication of the proportion of prisoners that are receiving Hep C testing and treatment when it's available, when it's needed?
In prisons?
Yes.
Yeah, so Victoria, we do go into prisons. There's, St Vincent's have like a nurse-led program that's statewide. Testing tends to happen in the initial healthcare reception assessment. There's the National Point of Care Testing Program, however, have over the last couple of years conducted a lot of what they call high intensity test and treat. So they'll go in and do they'll get the whole muster and they will test as many as possible and rapidly initiate people on treatment. The short answer is testing data is very patchy. In terms of when someone gets recepted to prison. We don't really know. Some states and territories are much better at collecting that data than others. So Queensland, it's the paper form still. It's very, like, there's paper medical records. Same in South Australia. So they're not going to be able to get that data for us. Victoria, the system just doesn't seem to support that, whereas WA, for example, has an excellent clinical record system that will pull out all that stuff quite easily.
Oh, yeah. It does sound good that there's quite a large muster to avoid stigma, so everybody's getting tested, basically.
Yeah.
Thanks very much.
And the policy, I'll add that, like, in some, again, different jurisdictions have different policies, but Victoria's policy is testing will be offered within 24 hours of reception, but there's no kind of indicators, there's no metrics to tell us whether that happens.
Yeah, thank you.
And Bec, you mentioned that there was some data sharing from the program with the correction settings themselves, unless I heard that wrong. As in,
sorry, we share data with the corrections sites.
Yeah, in terms of like who's been tested and the results of that.
Oh no, oh heavens, no. It's all completely confidential. We ask people because we collect people's contact details if they, need to go into treatment, but also if they want to participate in other research, or we'll ask them if they want to give us their contact details. And as part of the consent process, we ask them for their best contact detail, and if there's anyone else that they could provide as a contact if we can't get hold of them, because inevitably phones get lost, phones get so we try and collect multiple points of contact, and if people want to put their corrections worker as a contact, they can do that, but we don't ask that at all. And we're very clear that their personal information isn't shared with corrections workers. Some people choose to share it with their corrections worker because they have a really good trust relationship. The other thing that we had success with was approaching the drug court. And they actually really got on board, and the magistrate made it so that if you went and got a test at the van, you got a credit, which I'm sure everyone knows what that means. It's kind of the carrot stick approach. And if you got a credit, then that would cancel out one of your black mark. That's reaching your,
Interesting concept.
yeah.
Incentivizing access to the service.